Hi, I'm Jeff Klein, editor of RadioGraphics, and today I'm pleased to have with us Dr. Dana Lin and Dr. Gina Ciavarra of the NYU Langone Hospital for Joint Diseases, who are the authors, respectively, of one of our featured papers in the current November 2017 issue of RadioGraphics. Their paper is entitled Adventures and Misadventures in Plastic Surgery and Soft Tissue Implants. Doctors Lin and Ciavarra, welcome to our podcast.
Thank you very much.
Thank you.
Dr. Lin, we'll start with you. You've written a really unique paper that addresses a group of patients that most radiologists encounter only occasionally. Could you tell us what brought you and your group to develop this education exhibit on this particular topic?
Sure. So actually, a lot of the cases actually were collected initially from my experience during residency in the emergency room. From the patient population that we had at Columbia, I often was looking at things I wasn't sure, what was injected or what implants they were, what they were called, where were they, where they're supposed to be, what they're supposed to look like. So, over time, we basically collected all these cases, collated them, did some reading, and thought that we're probably not the only ones who don't know what these things are. And especially with these patients, looking up the information in the medical chart actually usually is not that helpful because the patients may not consider it a medical procedure, so they don't mention it to the physicians for medical or surgical history. And even if they do provide the medical history, they do say that they had a procedure done, they don't always necessarily know what was injected or what was done. So, and it was done either, outside of the country or it was done off-label inside of the country. So it's very difficult to know, what actually happens and easy to come across as a radiologist. So we thought it'd be nice to create this sort of resource for people so that you don't spend a lot of time Googling, point of care.
That's great. Thanks so much. Dr. Ciavarra, in the paper you begin by detailing abdominoplasty, or as commonly known, the tummy tuck, and that of liposuction, which are two of the more commonly performed cosmetic procedures that we see. You then proceed to detail autologous fat grafting. Can you describe this procedure? And we'll also look at Figure 5, which illustrates one of the complications of this procedure.
So autologous fat grafting is sort of a newish procedure that involves basically harvesting fat from a part of the body where it's less desirable to have fat, such as the abdomen or the thigh, and grafting it to an area where people might want more fullness, such as the breasts or the buttocks. So this has come into favor because it's felt to be more natural by the patients. It's their own body part. It's fat. It's not some synthetic injectable. So what typically happens is that through various means, either suction or just cutting out fat from the donor site, it is then transferred by injection into the recipient site. Basically, as with any surgical procedure, if it's not done appropriately, if it's not done under sterile conditions, you can run into problems of infection, seroma formation, hematoma, and the like. And in Figure 5, this was a patient who actually had it done outside of the country. She had fat grafting in both the face, and we didn't have imaging for that, as well as for sculpting of her deltoid area. And she developed a large multiloculated abscess that required drainage.
Right. Thank you. Gina, let's discuss liquid silicone injections. Can you detail the interesting history behind the use of silicone injections for cosmetic augmentation? And we'll show Figure 7, which shows a case of gluteal augmentation, and also Figure 9, which shows a complication of this procedure.
Right. So the interesting, this goes back to actually World War II, where silicone, which was being used for military purposes, was actually repurposed for use as an injectable. And it started in the Japanese prostitution industry because in order to be more appealing to the servicemen from the various parts of the world, they were getting these injections into various parts of their body. So that's where it began. Part of the problems initially were that it was obviously not done under sterile conditions. It was free silicone and it was able to migrate. So then they began combining it with things that would incite an inflammatory reaction, such as olive oil, cobra venom, and peanut oil. So to incite an inflammatory reaction that would keep the silicone in place. Unfortunately, though, this created such an inflammatory reaction, as we've seen in breast imaging, it can really obscure what you're trying to look at behind the silicone. So now today in this country, it's actually outlawed with the exception for certain eye conditions such as retinal detachment. So just moving to, so when we see it, it's actually, we typically see it performed by unlicensed clinicians might not be the right word, but unlicensed practitioners. It's frequently seen outside this country. And that's why we have a high incidence of infection associated with these procedures, because they're done under non-sterile conditions. So just looking at figure 7, this actually was a patient who it went more or less okay. He was an HIV positive patient who developed one of the complications of HIV, which they don't know whether it's caused by HIV itself or the retrovirals, is they can get lipodystrophy, and this can manifest as hypertrophy or atrophy. And this patient, you can see, is very thin and emaciated, does not have a lot of subcutaneous fat. So his manifested as lipoatrophy, which he decided to, we're not sure whether he had it in this country or abroad, he had free silicone injections into subcutaneous tissues to get more form back into his buttocks, for the purposes to counteract this lipoatrophy, which he had. So we see multiple dense subcutaneous nodules in the limited subcutaneous fat he has around his buttocks. In figure 9, what's happened here is this patient has had free silicone injections into the buttocks. We see multiple subcutaneous nodules that are, some of which are calcified. And then as a complication, she developed in the right ischiorectal fossa a large abscess that contains fluid and air, because this was presumably done under less than sterile conditions.
All right. Well, thank you for that. Dr. Lin, let's discuss the use of silicone implants for body sculpting, which is a more recent phenomenon. Can you describe the use of these for various indications? And we'll also show figure 13, which illustrates different implants as demonstrated on CT.
Sure. So body contouring or body sculpting with silicone implants was developed in the early 1990s. They thought this was related to the preceding cultural emphasis on bodybuilding and fitness from the 1980s. And these silicone implants can be used for various purposes, for cosmetic or reconstructive purposes. And they can be used to augment the musculature. So we commonly see them in the calves, in the pectoralis muscles, in the gluteal areas, in the shoulder and upper arm musculature. And they can be used, like I said, for cosmetic purposes to augment the musculature, or for reconstructive purposes, actually. So for people with muscle atrophy, either congenital or traumatic etiologies, also neoplastic purposes, like if you had a resection and then developed atrophy related to the resection, then you could have augmentation with that. Poland syndrome, pectus excavatum, chronic pectoralis major tears with associated muscle atrophy. These are all situations sort of that are more reconstructive than cosmetic. Certainly we see a lot of patients that get the augmentation just for cosmetic purposes as well. And recently these silicone implants have also been used for smaller areas for facial augmentation, such as the nose, the cheek, or the chin. So they're developing more and more purposes for this type of silicone implant. And one of the things that I thought was interesting while I was writing the paper was, so in figure 13, for example, you can see different densities of silicone implants. And the most commonly encountered silicone implant that we see as radiologists is probably the breast implant. That's actually made of silicone, highly cohesive silicone gel, whereas the silicone implants that are used for muscular augmentation are made of solid silicone, and that has to do with what the desired consistency of the implant is, depending on where the location it is. So in figure 13, for example, in part A, you see, subpectoral implants in a man who wanted to have, pectoralis major sort of augmentation for muscle purposes, and so that's, where firmness is very desired. So part B, though, you see implants in the exact same location. They're subpectoral locations, but this is for a woman who had breast implants, and because the cohesive gel is slightly less dense or less viscous, the density on CT is less also. And then in part C, you see muscular implants put in for biceps and triceps augmentation, and those are sort of intermediate density, and some of this has to do with what the manufacturer's preparation is. And part C also shows that the solid silicone muscular implants can be either put in intramuscular or subfascial locations. For the biceps, it's intramuscular, and for the triceps muscular implant, it's subfascial, and those have varying types of complications also, which we mentioned in the paper.
Great. Well, thank you for that. Dr. Ciavarra, moving on to soft tissue fillers. These have significantly increased in popularity over the past decade, as you detail nicely in the paper. Can you review where these are used? And we'll show an example of this in figure 16 as you describe this.
Okay, certainly there's a lot of overlap in terms of the autologous fat grafting and what Dr. Lin just talked about with the silicone implants. Basically, this is instead of grafting fat, which can also be used as a soft tissue filler, there are various polymers that are made of either collagen or plastic polymers that can be injected into various parts of the body, but most commonly in the face and in the hands for patients who develop wrinkles or kind of soft tissue wasting where they want to have augmentation to restore the normal body contour. So some of the, as I mentioned, some of the polymers are either calcium hydroxyapatite. It can be collagen. Can also use platelet-rich plasma, and there are various other varieties. Some of the complications, as with again any procedure, include infection, hematoma, seroma formation. You can also get foreign body reactions over time to the various polymers because it is an unnatural substance being placed into the body. And in the case of facial fillers, if they're done too close to the eye, you can actually develop blindness due to retinal artery occlusion, which is kind of a scary prospect, certainly. In this country, it's almost always performed under sterile conditions, so infection is a very unusual complication. But when it does occur, it can most commonly is Staph aureus, or when it's an atypical infection, usually more indolent or long-term infection, it's an atypical mycobacterium. So in figure 16, what we're seeing is actually a normal appearance of somebody who had facial fillers for malar augmentation, and it's not, it was not a complication. She was not being imaged for this. It was a brain MRI, but it shows the multiple lobules of the polymer underneath the skin in the malar region.
Right. Great. Thank you. So, Dr. Lin, the section on breast augmentation reused some material that I think most radiologists are relatively familiar with. However, the issue of textured breast implants as they relate in particular to non-Hodgkin's lymphoma is something that I think is probably not well known by most radiologists. Can you discuss the issue related to this as it's currently known?
Sure. So starting around, I think it was 2011, the FDA was basically gathering medical device reports regarding textured surface breast implants. Well, actually, it was breast implants in general, but specifically there were like 359 medical device reports of what's now called breast implant-associated anaplastic large cell lymphoma. It's a very rare type of peripheral T-cell lymphoma that, you know, women with breast implants are at increased risk for, but it is still exceedingly rare. And there's still not a lot of information about it, but it is on the FDA's radar, and people are trying to collect information from various countries to see, you know, what they can find out about it. What we do know is that of those 359 medical device reports, of the implants that had any information on the type of surface that was used, 231, I think, were there is information on the surface, and of those, like around 203 were textured. So it seems like the vast majority happened to be the textured surface type of implant. So the textured surface implant was actually, you know, gained popularity mainly because it reduces the risk of capsular contracture, which is capsular tightening that can lead to distortion and firmness that's undesired. So basically, you know, there are various theories about what might be happening. Some think that maybe there's some component of chronic inflammation or biofilm, a sort of development on the surface of the textured surface implants that is then giving rise to recruitment of the immune system and then over time lymphoma. Typically, on average, the lymphoma seems to develop almost a decade after placement, so it's not, it can develop early or even later, but generally speaking, what I've read out there is that it's about a decade out. And it's also more commonly in patients who are undergoing revision for a long-standing persistent peri-implant seroma. So the textured surface and then the peri-implant seroma, sort of persistent peri-implant seroma, are the only sort of two details that we know so far as being sort of associated with developing this type of lymphoma. As far as from a radiologist perspective, there are so far no imaging recommendations, you know, after placement of these implants for us to be known, for us to know about in terms of surveillance or anything. And certainly the FDA hasn't recommended prophylactic removal of these implants in women who have them. And from the patient's perspective, the FDA doesn't recommend any change in routine medical follow-up after placement. It's something just to be aware of.
Right, absolutely. Thank you for that. So, Dr. Lin, the final part of the paper deals with penile implants. Can we discuss the hydraulic implant that's the most commonly used implant and that our abdominal images are most likely to encounter when they're interpreting abdominal and pelvic CT? And we'll look at figure 24 that illustrates the issues related to the reservoir for these devices.
Sure. So the most common type of implant is the hydraulic inflatable prosthesis. It's composed of 3 parts, and it has a pair of cylinders in the corpora cavernosa. Then there's a scrotal pump, and then there's the reservoir, which you mentioned. And the reservoir is traditionally placed in the perivesical space, although it can also be placed along the anterior abdominal wall, deep to the rectus abdominis muscle, but superficial to the transversalis fascia. It can even be placed even lateral to the rectus abdominis, so either above or below the periumbilical region, and then even more lateral, deep to the internal or external obliques or the transversus abdominis. So those are sort of the most common places that we would see the reservoir. And so, the prosthesis works through compression of the scrotal pump, which transfers fluid from the reservoir to the pair of cylinders in the corpora, and then basically release of the valve in the pump then retransfers, returns the fluid back from the corpora back into the reservoir. And in figure 24, we can see one type of the complications that happen with these prostheses, which is migration of the reservoir. In part A, this is just an example of the normal position, one of the normal positions of the reservoir, which is deep to the rectus abdominis. In part B, there's migration of the reservoir into the bladder, which has an air fluid level. And this actually, in this case, happened immediately post-prostatectomy for prostate cancer. This is a little bit atypical because actually this type of migration and erosion into the bladder typically occurs further out from the procedure, and that has to do with erosion over time through the bladder wall. And then in part B, it's just migration of the reservoir into the adductor musculature, which is not a known position of having a reservoir. So, I think that at least, when I was reading cases in the ER, oftentimes we say, penile prosthesis in place and don't really check where the things are. So it's just important to know that, where the expected locations are and to check for migration.
Great. Thank you so much for that. Well, Dr. Dana Lin and Dr. Gina Ciavarra, I want to thank you for taking the time today to discuss your paper that is in the current November 2017 issue of RadioGraphics, which deals with the imaging of plastic surgery and soft tissue implants. Doctors, thanks very much for your time today.
Thank you very much.